From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Clinical Reviews podcast. Thanks for being here. I am Dr. David Simel, JAMA Associate Editor and Professor Emeritus of Medicine at the Durham Veterans Affairs Medical Center and Duke University. In this podcast, we will be discussing autosomal dominant polycystic kidney disease in adults. I'm joined today by Dr. Nerra Dahl, who is a professor of medicine and director of the Polycystic Kidney Disease Foundation Center of Excellence at Mayo Clinic. Dr. Dahl is the senior author of our narrative review on polycystic kidney disease in the March 24, 2025 edition of JAMA. Dr. Dahl, thank you for joining us today.
Thank you for having me. It's my pleasure to be here.
Let's get started with exactly what polycystic kidney disease is, because the genetic variant that causes this disease is now well understood. Could you describe the variant to us and explain how it leads to cyst formation?
Polycystic kidney disease is an umbrella term that we use when we're thinking about kidneys in which there are bilateral and multiple renal cysts. And in general, for polycystic kidney disease, the kidneys are enlarged. And that disease is caused primarily by two genes, PKD1 or PKD2, with PKD1 being the more common. And PKD1 and PKD2 encode for proteins called polycystin 1 and polycystin 2. And these proteins interact with each other in an organelle that we think is particularly important called the primary cilium. This protein complex sits on the primary cilium and senses what's in the environment around the cell. So it's sensing flow or changes in concentration or changes in the speed of things passing by this primary cilium. So any place where we expect to see this normal functioning and the functioning is gone, we can see an impact in PKD, in polycystic kidney disease. In the liver, it leads to cysts within the biliary epithelium coming from the bile duct cells. Within the kidneys, it leads to cysts coming from the renal tubular epithelial cells. Within the blood vessels, it leads to weakness in the blood vessel wall that can lead to an aneurysm. We worry most about aneurysms that might be forming in the brain, so intracranial aneurysms, but it can also lead to dilation of the aortic root, for example. So anytime you think of a place where there's flow, there may be an impact of these abnormal polycystins, but those are the major areas we think about for polycystic kidney disease.
Well, the inheritance of the disease is autosomal dominant, but patients certainly can arise without a family history. What are the clinical characteristics in those patients?
The patients who don't have a family history, so I would say about 80% of the time, patients have a family history. Someone, an immediate relative, either the mom or the dad, has polycystic kidney disease. But in about 20% of the time, there's no family history. And most of the time, that's because there's been a de novo mutation or a new mutation that happened at the time of embryogenesis in that individual. And those patients without a family history tend to present a little bit later on. It's about 5 or 10 year difference in terms of the time of initial diagnosis for those patients without a family history. Those patients tend to have more genetic variability in that they may have PKD1 or PKD2 variants, but they may have other variants that look similar to that are in part of that PKD phenotype. So those patients could have milder disease. They may have aggressive disease and just a new variant in PKD1 and PKD2.
The presence of incidental simple cysts on the kidneys or the liver seems pretty common with advanced imaging like ultrasound or CT scanning. In the patient with no family history of polycystic kidney disease, how do you sort out whether they are truly incidental or indicative of the inherited disease?
So this is a really important question, and it's a question that I think we often face in an internal medicine practice, looking at imaging and trying to decide, is this consistent with aging? So we know that patients as they get older tend to have more kidney cysts, or is it another process and potentially a genetic process? One way we start to look at this from a kidney perspective is we say, if there are a lot of cysts in someone who's young, then we're very concerned that that could be a potential genetic cause. The definition for people without a family history is at least 10 cysts per kidney, but we're really looking also at whether those kidneys are enlarged, whether the number of cysts is very high for that person's age. So seeing even 3 or 4 cysts in someone who's 20, for example, might be a sign that there's a genetic condition, whereas seeing 3 or 4 cysts in someone who's 80 might not be a sign of a genetic condition. So we're really looking at the age, the morphology of the kidneys, how the cysts are affecting the kidneys, whether the kidney volume is enlarged or not, before deciding whether or not there could be a genetic component. And then if we're still not certain after looking at the imaging, we would order genetic testing to know for certain whether that person has a PKD genotype.
Well, the genetic defect is obviously present at birth. So how long does it take for the first cyst to start appearing? You mentioned 20 to 30 years old. Do most patients with polycystic kidney disease have cysts by that age?
By 20 to 30 years old, most patients with either a PKD1 or a PKD2 genotype will have cysts. And so that's still the first and best screening test, is an ultrasound to see, are there cysts within the kidney? And for patients with a family history, we can look at the number of cysts at a person's age and say pretty definitively whether they have PKD. For patients without a family history, the suspicion is higher for more cysts when they're younger.
Do we need to do genetic testing in the patient with no family history?
We recommend genetic testing in a patient with no family history because the genotype can sometimes help us also predict prognosis. We know that patients with PKD1 genes and particular type of PKD1 variant are the patients at highest risk of progression, but people with the other variants have milder disease. And so getting that genetic information can help establish a prognosis.
Tell me a little more about the natural history of polycystic kidney disease.
The natural history is, for most patients, childhood is pretty normal. We tell families with children at risk for PKD to monitor for the early development of high blood pressure or kidney pain or blood in the urine. But otherwise, for most patients, the early childhood, early adulthood is fairly normal. I think as patients move into their 20s and 30s, there can be the development in patients who are at high risk of high blood pressure or a urologic event such as a urinary tract infection, hematuria, or a cyst kidney stone, or cyst rupture, something like that. We think of the development of high blood pressure before the age of 35 or a urologic event before the age of 35 as a high risk feature for ADPKD. And hypertension can be one of the earliest signs of disease progression in ADPKD. So that would be early on into the young adult years. Into the later adult years, about 50% of patients will develop kidney failure by the age of 62. And in that time period, in those decades between the 20s and the 60s, other things can happen. So cyst rupture, bleeding into a cyst, kidney stones, kidney infections. And so we're also monitoring for those things. We're monitoring for changes in blood pressure, monitoring for changes in kidney function. Then starting to talk to patients about the need for some kind of renal replacement therapy, either dialysis or transplant. All of those other extra renal parts of PKD continue as well. So thinking about who's at risk for intracranial aneurysms, thinking about who's at risk for having large livers from having polycystic liver disease. We're monitoring those things as well. There are some special considerations during pregnancy for people with ADPKD that we discuss in those childbearing years, and then monitoring for increasing cardiovascular outcomes as people age with PKD.
In the absence of acute event like kidney stones or bleeding into a cyst, is pain a prominent feature of these patients' lives?
For some patients, pain can be a very prominent feature. We know that pain in PKD is described as a dull pain that's sort of chronically there, and then exacerbation of that dull pain, and then acute sharp pain. So we worry about the acute sharp pain as being a kidney stone or bleeding into a cyst or rupture of a cyst. But people can be very bothered by that dull, aching, chronic pain as well. And it's one of the things that we ask when we see patients, what their bother score is and how well they're able to function and do the other things that are important in their lives with that pain burden.
Well, you mentioned early on that polycystin is expressed in the liver and that you can have liver cysts. Are those present in all patients, and do the liver cysts cause problems similar to the way the renal cysts cause problems?
Liver cysts are present in all patients as patients get older. So by the age of 35, 90% of patients will have some liver cysts. However, in most patients, those liver cysts are an incidental finding and cause no problems at all. In about 5% of patients who will develop full-blown polycystic liver disease and will have enormously large livers. And then liver synthetic function is never compromised, but there can be other issues just because the liver is so large. So people may have difficulty with simple tasks, bending over, for example, because the liver is so large. Or the liver cysts could be causing obstruction of the bile ducts and impairing bile flow. Or the liver could be large enough that it's impairing, pushing against the stomach and then causing early satiety or increased reflux or other problems. So people with these very large livers can be fairly symptomatic from having this.
Let's circle back to aneurysms. Should all patients be screened for intracranial aneurysms?
We think all patients with a family history of intracranial aneurysms should be screened. In that population, the risk of having an intracranial aneurysm is about 20%. The risk of having an intracranial aneurysm without a family history is probably about 10%. For those patients without a family history or with an unknown family history, we have a conversation about the risks and benefits of screening. What we know about aneurysms is they tend to be small and they tend to be slow growing in ADPKD. So even though there's an increased risk, there's a chance that we would find an aneurysm and then require the patient to have more monitoring over time. For all patients, we have this conversation and say, this is your individual risk, and then discuss what the risks and benefits and cost of that screening and monitoring would be for the patient.
Well, you described what sounded like an inexorable decline in kidney function to, if you live long enough, eventually needing kidney replacement therapy. What simple things can be done to slow the rate of decline in kidney function?
So first and foremost is paying attention to the blood pressure and treating high blood pressure or hypertension when it's present. For the people at highest risk of early loss of kidney function, we're very aggressive about blood pressure control. So we target a blood pressure in these younger patients of 110/75. And that seems like a very aggressive challenge, but most of the time we're able to achieve that blood pressure goal in our younger patients. For patients who are older, we're targeting a systolic blood pressure less than 120. So that would be the first step. The second step is dietary and lifestyle management. We think that salt stimulates cyst growth. We know people who have more salt in their diet have a faster rate of cyst progression. So we counsel very extensively about how to follow a low salt diet and what that really means. We know that cyst growth is faster in people who are overweight or obese, so we counsel extensively on following a healthy lifestyle and maintaining a healthy weight. And then for people who are at highest risk, we also talk about therapies, including Tolvaptan.
Well, let's talk about Tolvaptan. What is Tolvaptan, and what is its role in the treatment of patients?
Tolvaptan is a vasopressin receptor antagonist, particularly the V2 receptor antagonist. And what it does in the kidney is it blocks the role of ADH. So people who take Tolvaptan make very dilute urine. They're thirsty all the time, but also urinating frequently. So someone who gets Tolvaptan is making in the order of 6 to 7 liters of urine a day, someone with preserved renal function. And we think that what is happening internally is that vasopressin stimulates cyclic AMP within the renal tubular epithelial cell, and that cyclic AMP drives then things that lead to cell proliferation, to fluid secretion within the cysts. And so if we can block the action of that cyclic AMP with blocking the action of vasopressin, we can decrease the proliferation needed for cyst growth and decrease the fluid secretion into cysts. So that's how we think Tolvaptan is working. And what we see from the data is that Tolvaptan slows down the rate of loss of kidney function by about 1 mil or 1% per year. And so we really are trying to get people started on Tolvaptan the same way, like for diabetic nephropathy, we try to get people started on an ACE inhibitor or an SGLT2 inhibitor early in their disease course so we can have the benefit of an extended period of time in which to treat. And that's true with PKD, with Tolvaptan as well, that we're trying to start as early as we recognize that person is at high risk as possible.
When you mention a decline, it slows by 1% per year. What is the actual clinical implication of that?
The clinical implication of that is depending on the time that we start treatment, we may gain as much as 5 to 10 years of slowing down the onset of end-stage kidney disease. So ultimately, what we're trying to do is delay the onset of kidney failure or end-stage kidney disease. And we think that if we start, for example, when someone's in their 20s with well-preserved kidney function, we may gain as many as 10 years. But for someone that we're starting later, maybe now in their 40s or 50s, we may gain only a small fraction of that time before they develop kidney failure, maybe 3 to 5 years. And so we're really starting the treatment for anyone with a kidney function, a GFR greater than 25, but really thinking carefully about who is most likely to benefit, what's the time that they'll benefit from being on therapy.
What are the adverse effects of Tolvaptan?
So the most common adverse effects are related to the blocking of vasopressin, so polyuria, frequent urination, having to drink the 6 liters or so. Those aquaretic side effects are the reason that most people who withdraw from Tolvaptan therapy withdraw. It simply creates too much burden for them in negotiating their lives to be able to manage all of those side effects. The side effect we worry about the most is liver toxicity. And the liver toxicity, about 5% of people who get started on Tolvaptan will develop liver LFT abnormalities. Very few numbers of those patients develop significant liver disease, but there is a risk of developing very severe liver failure with Tolvaptan. And for that reason, there's a REMS in place for everyone who starts Tolvaptan in the US, and that REMS includes checking LFTs at baseline, at 2 weeks, at 1 month, and then checking them monthly for the first 18 months and every 3 months after that, as long as the patient remains on Tolvaptan therapy.
So the REMS means that those are required monitoring and surveillance?
Yes, it's required by the FDA.
For the patient who's approaching a requirement for renal replacement therapies, what are the outcomes from kidney transplantation?
The outcomes are generally excellent for kidney transplantation for patients with ADPKD. The patients with ADPKD tend to come to transplant earlier and tend to have fewer cardiovascular outcomes than, say, for example, a similar patient who developed kidney failure from diabetes might. And so really these patients do quite well, and we expect high transplant success rates and a functioning transplant for 10, 15 years, depending on the donor organ health at the time of transplant.
When the transplant is done, are both native kidneys removed?
Whether or not a native kidney needs to be removed is really an individual discussion with that patient and their transplant team. For patients who have massively enlarged kidneys or have frequent bleeding or frequent infection or have really severe pain, we may discuss removing either one or both kidneys at the time of transplant. But what we know is that over time, after kidney failure occurs, the kidneys will get slightly smaller. And so for someone who's not very bothered by their kidneys, we'll leave the kidneys in place at the time of kidney transplant and just follow their course and see how they do.
Well, is there anything else you would like our listeners to know about autosomal dominant polycystic kidney disease?
This is a genetic disease, and I think what we're learning is the genetics are more complicated than we thought initially. And I think there's a new interest in thinking about genetics, and we're at the cusp of sort of thinking about genetic therapies. It's a disease potentially where we'll see treatments change a lot within the next 5 to 10 years, which is really exciting for those of us who are in this field and also for the patients who have this condition and are thinking about their futures.
Well, thank you, Dr. Dahl, for joining us today to talk about polycystic kidney disease. I am Dr. David Simel. This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio, all one word, .com, or search for JAMA Network wherever you get your podcast. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.